Good afternoon, everyone. My name is Nathaniel Brooks. I'm a neurosurgeon at the University of Wisconsin-Madison in Madison, Wisconsin. To my right is Choll Kim, neurosurgery or orthopedics? Orthopedics, and he's at Excel Spine in San Diego. Hoon Choi, neurosurgeon at the Cleveland Clinic in Fort Lauderdale, Florida. And Christoph Hofstetter, neurosurgeon at the University of Washington. Today we're going to talk about how to adopt endoscopic spine surgery. We have three experts here and one person who's interested, one surgeon who's interested in adopting endoscopic spine surgery. And we're going to try and bring up kind of the main questions that are asked, and try and explore this topic and give you some introduction into how to get into endoscopic spine surgery. So, Hoon, tell us a little bit about yourself and kind of what your interest is in becoming an endoscopic, in getting involved in endoscopic spine surgery.
Right. So, my journey began as a spine surgeon, learning the open techniques, and then I saw the value in minimally invasive spine surgery techniques. And then I transitioned my practice to MIS. Now I'm looking into the next natural transition is to go into endoscopic. I've done some procedures with the endoscope, and I wanted to talk about the transition, the needs, the patient education, the approaching the hospital administration, the indications, what's possible, and what's coming, and for all of us out there who are thinking about this, how to approach this in a safe manner, in a systematic manner.
So I think that's great. I want to kind of start with the experts here and get their kind of how they learned. Let's start there, and because some of you have been doing this for years and years, and some still remember what it was like to learn. But tell us a little bit about your experience.
Okay, so my experience on developing and adopting an endoscopic practice is probably going to be very different than what Dr. Choi might do. Because the way I learned is piecemeal, little by little, pretty much all on my own, with some guidance from Dr. Tony Young, who's kind of the father of endoscopic spine surgery in the US. But a lot of the things I learned through my own experience, little by little, and a lot of the tips and tricks that I now try to teach other surgeons, I had to learn on my own. So my learning curve was somewhat difficult and really extended over a long period of time. And that's going through courses, doing cases, talking with people, kind of on a catch-as-catch-can basis. So hopefully your experience will be very different. But I learned how to do this many years ago when it was new, when there was not a lot of resources.
So less resources and less structured
Yes.
would be the best way of putting it. And Christoph, Dr. Hofstetter, what's yours?
Joel, I think my experience was in fact very, very similar. I think it was 10 years ago, and there were courses, but they were not well structured yet. I think what has changed in the interim is there's now very sort of like well described and structured, curricula. The technique is taught by societies like NAS, but also like EOSpine, and all the major companies also have their teaching programs, and they're very well structured. So I think it has become much more standardized now. So, but it didn't used to be like that.
So either of you can answer this. If you were, now you're talking to Dr. Choi here, but what would you tell yourself to do now? How would you start now?
Well, let me. I'll take that one. So I think one thing that helps is first of all, making up your mind if that's something that you want to direct your career to. Endoscopic spine surgery is a whole field and supplements spine surgery, and you have to dedicate. You have to be sure that that's where you want to drive your career towards. And so I think once you've made that determination, then I think the best thing is to go to some of these courses, and then focus on one or two procedures. So I typically like to have people start either have two procedures available and be trained on typically an L5 4 or 5 transforaminal plus an L5 is 1 interlaminar, and do those procedures 30 times in the lab. Just do it again and again and again and again until you are confident that you can, do it safely in a patient. And then do those 2 procedures. They'll be enough to, fill you up and then slowly, advance your horizon.
And your thoughts?
If I had to do it all over again, the one thing that I did do well is to find a really good mentor. But what I didn't do is look at it as like a journey. So I went and visited Dr. Young for about a week. And then after that, like most surgeons, I feel like I know everything and I can figure everything out myself. I wish I would have kind of circled back with him a little bit more often at the beginning, because I think that would have eliminated a lot of my learning curve challenges. But practice is probably the most important thing. The other thing I would have done is attended a few more cadaver courses and really paid attention during those courses where I can just practice on in a laboratory setting.
Right. Yeah, I would say I went to 3 cadaver labs before I moved into doing this in patients. And then the other thing that I did, which seems to be a bit different than what, and I adopted later than you guys, seems to be a bit different, is that I chose to do the intralaminar endoscopic procedure as kind of my staging area, because I felt like I could convert that to an open procedure if I needed to, if I felt uncomfortable. Much in the same way when I'm teaching people how to use tubular retractors, I say do an open operation and then bring a tube in, work through the tube a little bit, then bring it out, finish the operation. That way you kind of have your ability to learn the tools, learn how you have to hold your hands, those kinds of things, and have something of a comfort level. But I think there's still other barriers that, besides just learning how to do the technique, that I think you touched on earlier. One of which is, how do you negotiate with your hospital that you're going to move forward with buying the equipment, those kinds of things. So, do you guys have thoughts on that?
Yes, it's been a challenge, and I think it's one of the reasons why the adoption has been slower than one would expect based on how much excitement there is around this field. But we're asking the hospital to all of a sudden pay for a whole new system for a surgery that we could do in their eyes for free, because we already have all the retractors and the microscope in the hospital. So in their mind, there's no added cost. When you start doing endoscopic surgery, now there's more equipment, there's some disposables, and you have to convince them that it's an important part of the practice. It's an important part of being a center of excellence, for example. And I really try as hard as I can making a clinical argument, but that doesn't always work, and persistence helps a lot.
Right, and you're in private practice, so from the kind of negotiations or discussions you were having, was there a lot of discussion about how much the margins were like, and those kinds of things on individual cases, and using disposables and those kinds of things?
Not at first, because 10 years ago those discussions weren't that common.
Yeah.
Now they're probably much more common. So the other strategy that I think is important is to try to figure out a way to implement that program like in an incremental way. So oftentimes we're asked to buy an entire tower with all the equipment, and that's a huge commitment. So if we can negotiate with the vendors to loan the equipment, rent the equipment, and then take some time to figure out just the basic equipment that you need to start with, because you don't need everything to start.
Right.
That has been a much easier sell and much easier to convince, because now instead of having a really big ticket capital purchase, we now have like case-by-case rental agreement. Right. In the end, purchasing is probably more economical, but just to get started, it's much easier to go through the OR committee than the capital purchase committee, at least in the hospitals that I was with.
Dr. Hofstetter, thoughts?
I agree with you. I think an incremental start eases this process. You can rent equipment at the beginning. I think for hospital administrators, it's important that you utilize the equipment, because the basements are full of stuff that is not utilized. So I think making sure.
And sorry to interrupt you, but you're in an academic institution, so it may be that they see a lot more of these kind of new procedures coming their way.
Definitely. And then you have I think once you plant the seed, there was immediate buy-in. I mean, I think from the hospital staff, from the OR staff, the PACU staff, they see those patients, and then there's really no way back once they send their own relatives. especially if once the administrators send their own relatives, because then all doors open up suddenly. And I think that's where it comes to. But I think it's really important for us also as a society to, make incentives for this, because the U.S. is trailing the world in this technology and in providing the best healthcare, the safest healthcare. We just, again, looking at 2,000 patients, and there's not a single infection of these procedures. So that means that we don't have the, comparative, numbers yet for MIS or open. But my guess is in 2,000 patients, there's probably 10, 15 infections with, probably pretty bad outcomes for these patients. So I think it's our obligation to move it forward.
Other questions?
So let's talk about what's possible, where we are in terms of indications and what techniques are available and what conditions we can treat. And we can talk about regular cases that you do and, sort of the pioneering techniques and what's coming in the future.
So just very quickly to run up, from the top down in the spine. Cervical spine, we routinely do our foraminotomies with endoscope. We routinely do laminectomies in the cervical spine, especially for the aging population. That's really a godsend procedure. All the thoracic discs, no matter if it's calcified or not, they're really, I think, in my opinion, those are going to be the first procedures where it's going to be standard of care to do this endoscopically. Because the alternative is dropping along, with risks to the patient and morbidities. Lumbar laminectomies, lumbar foraminotomies, discectomies, so those are the indications, and then single level fusions. Do you guys have any additional?
Well, hearing you talk, I've been doing this for a lot longer than Christoph, but now Christoph is like a light year ahead of me. I mainly used it to treat herniated discs, and it's highly effective. It's hard to show in a study, but the patients get back to work so much more quickly. So I think the best thing to do is to focus on a very common problem for which we commonly perform an operation for, because patients get better. So I would say that the vast majority would be for things like that. And then specialized problems in the neck and the thoracic spine should go to people at the academic centers that have been doing very complex surgeries for a long time. So I think that's going to be the niche, but herniated disc surgery is a bread and butter problem. So many people have that. And if you just are able to take care of those patients a little bit better, I think, in my mind, that's enough. But I think the future is, like you're saying, it's very similar to the knee and the shoulder. They do everything through an endoscope now.
Right. So then the most common problems that we face, lumbar disc herniations. Let's talk about different techniques and why you would choose a certain endoscopic technique over another, and depending on the anatomy and how you would approach the problem. Transfemoral and interlaminar.
Yeah, so I'll just, I think that one of the barriers I had to adoption was trying to understand what the transfemoral procedure could actually do, because that really defies the previous training that I had. And so, again, another reason why the interlaminar approach seemed to be the one that made more sense to me is that with that procedure, you can essentially do everything that you normally would do with an open microdiscectomy. And so the indications are well understood. You're going to be able to see the nerve as it traverses and see where it's compressed, and you can do that with the transfemoral as well. But until you get enough repetitions and enough mentoring, you can't always tell exactly what you're going to be able to do. That's at least been my experience. It's a little harder to know how far medial to the pedicle you can get, how far caudal from the disc space you can get, how far rostral, and all those kinds of things. And of course, without mentors, it makes it harder to do that, because you're doing it kind of learning on the fly, learning on your own, being very careful, but learning how to do those things and planning on your own. But I would say that the intralaminar L4-5, L5-S1 is going to be pretty much your standard disc herniation. The easiest cases to do are tall discs, with soft disc herniations, and that are going to be lateral, more lateral against the pedicle. Try not to pick patients who have migrations and even more centrally protruding discs initially. That's not to say you can't do that later on, but certainly the early cases. And then for transforaminal, you're gonna obviously far lateral and foraminal disc herniations. Those seem like an obvious choice, but as you start to do more and more of those, you'll start to see that you can actually get more medial than you think, and that you have a good opportunity to get into the canal and deal with disc herniations there. And that's kind of been my slow process into working that direction. Overall, I think endoscopy is essentially more of a platform technology. So you pick up the lumbar cases and you learn the lumbar cases, but you can do more complicated things. And not to say that the sky's the limit, but nothing in surgery is like that. Everything has its pros and its cons, and so I think that you will be able to use it not only for lumbar pathology, and that includes lateral recess stenosis and central stenosis, but thoracic disc problems, thoracic pathology, and then of course cervical. Another common problem, of course, is foraminal stenosis and disc herniations, which can be treated quite effectively. We've run out of time.
One more question.
I'm going to get one more question out of you. There we go.
What are some of the downsides or cautionary tales?
The biggest downside, in my mind, is the challenging learning curve. So I think I've said this before. It's sort of like if you're a golfer trying to transition between cavity back irons and blade irons. So I'm a cavity back iron player. But the professionals on the PGA Tour, they play with blades, which are much more difficult to hit. But once you learn how to hit that, you're never going to go back to cavity back because the ball goes further and you can shape it and make it do things. So if you can get past the learning curve, you're like us three. We look at cases, we're like, why would you do that open? Why would you do that endoscopically? And the only reason why everyone else isn't like us is that there is a very difficult learning curve. It's steep and it's long, but that is a problem that I think is very solvable. We just have to sit down and solve it. Not just say that it's a difficult problem, but dissect it out, identify what's difficult and how that can be addressed. It'll probably be different for everybody, but if you don't prepare for your first few cases correctly, you will have a problem. And the most common thing is the postoperative radiculitis. It tends to be temporary, but it is very distressing to both the patient and the surgeon.
Right.
So I would say that that's the biggest thing that we should focus on trying to address. There's a bunch of other serendipitous challenges, but that one clinical challenge is, if I had to choose, that would be the one I'd go after first.
And I just want to make a kind of a segue or comment about the learning curve and hear Christoph's thoughts on this as well. Sometimes I think the expectations are too high. Like when we learned how to do the open microdiscectomy, we learned how to do it over 7 years, and even after we learned how to do it, we still, when we were first started in practice, we still were figuring it out. And with endoscopy and even a lot of new procedures in spine surgery and neurosurgery, sometimes there's this expectations that you're going to figure it out in 20, right? You figure it out in 20 cases, and that's all you need. But the reality is that there's going to be a slow adoption process, and you have to allow yourself that. You have to give yourself the leeway to get into that. But it does require a bit of a leap of faith on the early part. And then, Christoph, I don't know what your thoughts are. We both train residents, so we kind of see a different version of adoption, right?
Yeah, no, I think the learning curve is a big issue. But I think as long as you focus on one or two procedures and really hone in on these two procedures and enjoy the good outcomes together with your patients are going to motivate you to keep going. Just a little story. In my institution, we set up a prospective study, open versus endoscopic laminectomy. The hospital administration didn't care. The IRB was fine with it. You know who stopped it? My clinic staff, because they didn't want to deal with these patients anymore, having leaks from the wounds and drains to pull. They were like, no, why would we do that?
They stopped the open arm.
Yeah, they stopped the open arm. And so, I think that's kind of a little story to that. But it is, it's a way. I think for me, it's the only technology where you teach a course, and afterwards the surgeons come up to you and are like, I think I need this procedure done. You will not teach another course as a surgeon where actually the participants will come to you and be like, hey, I think I might need that.
For a patient, as a patient.
As a patient. Yeah.
I've noticed that too. I take care of an extraordinarily large number of physicians, nurses, and their family members. It's shocking.
Yeah.
And that says something to me anyway.
Absolutely.
So I'd like to thank everybody for their expertise and Dr. Choi for being the learner here. That's great. And I hope this gives everybody in the audience a little bit of a primer. Of course, we are all available to try and answer these questions in person as well in the future, and in labs and those types of things. So thank you very much. We appreciate your time.
Thank you.
Thank you.
Thank you.